Before I begin, I have one disclosure. I wrote this book that I based a large part of this talk from. The rest of this talk is from research and testing that I did in preparation for this book. I get a portion of every sale. This talk is a beginner's guide to making a diagnosis in emergency medicine. Why talk about making a diagnosis? Arguably, it's one of those soft skills that we all pick up along the way, incidentally just going through the process of medical training. However, I've found that students and residents gain these soft skills much more quickly if they have an organized way to approach making a diagnosis. And I'm presenting some of that material here. I intend this talk for junior clinicians, especially interns. However, instructors may find this talk a useful resource to share with their trainees. What we're going to talk about is a framework, or a map, to making a diagnosis. It's an organized approach to the patient during the act of taking the history. This framework will help you organize your history, again like a map helping you navigate. This is not the final answer in your history taking. This is a beginning, a strategy to give you a good start, and a way to quickly make the medical knowledge you already have functional. After you've seen what the chief complaint is, maybe even before you see the patient, come up with a couple potential diagnoses that the patient may have. Good places to start with are: what is the most dangerous disease that could cause this patient's symptoms? And what is the most common disease that can cause this patient's symptoms? What you're going to do is use process of elimination to try to get the diagnoses off the list. You're essentially trying to cross the diseases off of the list that you make. With this strategy, you are largely directing the narrative, not the patient directing the narrative. You have to get the specific details regarding the disease processes on your list. These specific details are very important in keeping a diagnosis on your list or crossing it off the list. Sometimes this means using yes or no questions. Be like a detective trying to get to the bottom of the mystery. Keep chasing these details until you have a definitive answer, and until you have enough information to determine whether to keep a disease on your list or to take it off. Traditional teaching recommends open-ended questions. While these certainly have value in that they generate leads for you to follow and fill in gaps in the patient's story that you may not have thought about, asking only open-ended questions is ineffective. And we'll be getting to this a bit more in the next slide. Like we said, non-specific, open-ended questions certainly have value. They can clue you into what is going on and fill in the gaps of the history that you may not have thought of. However, using them exclusively is not efficient. The patient may not volunteer what you are looking for, or may think you are asking about something else. You'll usually need to add specific questions to get the necessary details for the diseases on your list. Remember, the details specific to the disease on your list are important. You have to pin down those details. The patient may have other details they want to give, but there are specific details you need to get to rule out the diseases you have in mind. Get those details and prioritize them. Like I mentioned, many times these questions will be of the yes-no variety. We're going to see how this works with a classical example in emergency medicine: chest pain. Let's say we want to assess for acute coronary syndrome. A non-specific question would be, where is your pain? A more specific version of this question would be, is your pain on the left, the right, the middle, or all the way across? A non-specific question would be, what makes your chest pain worse? A more specific version would be, does your pain worsen when you walk? Non-specific question, do you have any other symptoms with your chest pain? Some specific variations would be, do you have any nausea and vomiting with your chest pain? Do you have shortness of breath with your chest pain? Being suspicious about a disease and being specific about the details will bring you a long way. You will be able to rule out a lot more diseases than you initially think by using this method. With practice, you can certainly have more than 2 diseases in mind when you go to see the patient. If you're comfortable trying more than 2 diseases in mind, certainly try. However, I usually recommend most beginners start with only 2 diagnoses. This strategy that I'm outlining boils down to pattern recognition. The more patterns you know, the more likely you are to make the diagnoses. When you are looking out for those diagnoses, you are more likely to find them or to rule them out. As a medical school instructor once told me, if you don't think of the diagnosis, you won't make the diagnosis. Once you learn a new disease pattern, you should actively search for it when you see your patients. How do you learn more patterns? It's simple. You see more patients and you study. There's no secret. Keep in mind that this is just a start. This is not the end. And remember that you have to put in the effort. No one else can do it for you. However, having a framework to functionalize what you already know makes you more efficient in how you use your efforts. That's the end of this talk. Use some of these concepts when you take the history from your patients, and you will have a good start towards becoming an expert clinician. Thank you.